Hello everyone, I am Dr. Ajinkya Borhade, Assistant Professor in Cardiology at UNMICRC Institute of Cardiology and Research Center in Ahmedabad. So today we are going to discuss an important, crucial topic of management of AF in patients who are undergoing percutaneous coronary interventions. So atrial fibrillation is the most common arrhythmias in patients undergoing PCI. 1 in 4 individuals develop atrial fibrillation in a lifetime, and once the atrial fibrillation, once the patient has atrial fibrillation, it increases the risk of stroke for about 4 to 5 times, and 15 to 20% of ischemic strokes are because of atrial fibrillation. So the patients with atrial fibrillation, they require chronic anticoagulation, chronic oral anticoagulation for the prevention of cardiac thromboembolism. Oral anticoagulants is associated with significantly lower stroke rate as compared to antiplatelets. The guideline supports the use of oral anticoagulants in high CADVAS score. Now we see the coronary artery disease, acute coronary syndrome. This is the most common life-threatening presentation in cardiology. PCI is a standard treatment in most of the cases, and they require DAPT in the form of aspirin and P2Y2 inhibitor to prevent the complications of thrombotic complications post-PCI. So AF in coronary artery disease. So both of these pathologies have a common risk factor, that is hypertension, diabetes, obesity, obstructive sleep apnea, smoking, etc. And inflammation is a common pathological milieu in both. Incidence of AF in coronary artery disease is anywhere between 17 to 46%, and approximately 21% of such patients require PCI or CABG. The clinical challenge here lies that when we prescribe both the oral anticoagulants and DAPT as a triple therapy, there is a risk of high bleeding risk. Hence, to tackle such patients patients with undergoing PCI with atrial fibrillation, we have to manage both the thrombotic as well as ischemic and the bleeding risk together. Let's look at the epidemiology. If we see approximately 1 billion population in European Union and US, there are approximately 20%, that is 20 million people with atrial fibrillation, and out of that 16 million there is oral anticoagulant therapy is indicated. Out of that 4.8 million patients with coronary artery disease, and out of that 1 to 2 million patients the revascularization is indicated in the form of PCI and CABG. The key concepts here to note that the treatment of both atrial fibrillation and PCI is slightly different. Here we can see in a blue circle there is an elderly female who is suffering from atrial fibrillation. So to prevent the risk of TIA and stroke, she requires oral anticoagulant therapy more than DAPT. Oral anticoagulant therapy in the form of warfarin, dabigatran, rivaroxaban, apixaban or endoxaban. So here it is important to know that the risk of stroke and TIA is because of the lower shear stress, that is less platelet dependent thrombi, hence they require anticoagulant therapy more than the DAPT. Whereas in the other orange circle, this is a patient requiring PCI. So the patient requiring PCI is at a risk of stent thrombosis, and such patients require dual antiplatelet therapy more than oral anticoagulants like aspirin, clopidogrel, prasugrel and ticagrelor. So here there is high shear stress with platelet-rich thrombi, hence the antiplatelet therapy is important in such patients. So if we consider this patient, both of these parameters are there in the same patient, that is the patient suffering from AF and PCI. This requires a triple therapy which includes oral anticoagulant therapy and a dual antiplatelet therapy. Such therapy is associated with higher bleeding risk, which is the combination of these two. Hence, to avoid this, we have to have an optimal combination of anticoagulants and antiplatelet therapy, which should be balanced with bleeding risk and thrombotic risk. So AF and ACS is a double-edged sword. So patients with AF with recent ACS or have undergone PCI, they require anticoagulation for stroke risk reduction associated with non-valvular AF. They require add-on single or dual antiplatelet therapy for reducing the risk of ischemic events in ACS or PCI. Combining these regimens increases the risk of bleeding. Hence, we need an optimal combination of anticoagulant and antiplatelet therapy, which should be balanced with bleeding risk and thrombotic risk. So what are the various parameters to judge whether the patient requires the oral anticoagulant therapy? That is the CADVA score. So if the CADVA score is more than 2, if the patient is male, the oral anticoagulant therapy is recommended, and if she is female, it may be considered. There is a bleeding risk score also, which is called as Hasbled score. A score of 0 to 2 indicates low risk of bleeding. A score of more than 3 indicates high risk of bleeding. There is another risk criteria, that is BARC. I won't go into details. Here it is important to note the definition of the high thrombotic and ischemic risks. What are the patients who are at a high thrombotic risk, and what are the patients who are at high ischemic risk? So high thrombotic risk, this is actually an early event. So the patients which have acute coronary syndrome, a previous stent thrombosis while on antiplatelet therapy, a complex PCI in the form of 3 vessels treated, or more than 3 stents implanted, or more than 3 lesions treated. Bifurcation stents with 2 stents implant, total stent length of more than 60 millimeters, a surgical bypass graft PCI have a high thrombotic burden, a chronic total occlusion PCI, a use of atherectomy devices for calcified lesion, and left main PCI. High ischemic risk, this is a long-term event. This includes previous myocardial infarction, multivessel coronary disease, a polyvascular disease, a patient with diabetes mellitus, chronic kidney disease, and heart failure. So it is important to know which are the patients with high thrombotic risk, which are the patients with high ischemic risk, and which are the patients with high bleeding risk in order to manage such patients with AF and PCI. So what are the antithrombotic therapy we have for AF and PCI? So we can have a single therapy in the form of aspirin alone, or clopidogrel, or prasugrel, or ticagrelor. And we have warfarin and NOACs. Then we have a DAPT, that is aspirin along with clopidogrel, prasugrel, and ticagrelor. Then we have double therapy in the form of P2Y12 inhibitor plus warfarin, or P2Y12 inhibitor plus NOACs. And finally the triple therapy, that is aspirin, P2Y12 inhibitor, and warfarin, or aspirin, P2Y12 inhibitor, or NOACs. So as we can see, once we go from a single therapy to a triple therapy, as we increase the agents, there is always the increased risk of bleeding. And once we go on reducing these agents from triple therapy to single therapy, there is always an increased risk of thrombosis in such patients. So management of such patients in coronary stenting in patients with AF and high risk stroke, we have to avoid 3 major things. One is the stent thrombosis, another is the risk of stroke, and by usage of both DAPT and oral anticoagulants leading to major bleeding. So the optimal combination of these agents can reach up to 2.8 million different combinations. This is an article from JAC which shows that there are approximately 2.8 million different combinations, which can be very daunting on the practitioner of what to start and when to start and what to omit and what not to. Hence, the challenging and managing these patients with ischemic burden and bleeding risk is important. So what are the trials which support such management? So the first trial was Voyage trial. This was a landmark trial, which was an open-label, multicentric, randomized control trial, which included approximately 300 patients in 2 arms. First arm received an agent of warfarin with clopidogrel and aspirin. Another arm was dual therapy only, that is warfarin and clopidogrel only. So after elimination of aspirin, they found that there was reduced bleeding risk complications with the use of oral anticoagulant and clopidogrel alone as compared with the triple therapy, and there was no increase in the risk of thrombotic events. So the omission of aspirin drastically reduced the bleeding, that is occurrence of any bleeding episode at 1 year, a TIMI major and minor bleeding, gusto bleeding, BARC bleeding, or any bleeding events was significantly lower as compared with the triple therapy. Hence, at this trial, after this trial, we came to know that dropping the aspirin can be one of the factors which can help us in preventing major bleeding events, because they showed no risk of such increased thrombotic events even after dropping the aspirin. Another trial was Pioneer AF trial. Now, the problem with the Voyage trial was the use of warfarin. Warfarin needs to be titrated to be maintained in the therapeutic INR range. Also, the food and drug interaction is also a major factor there. Hence, the Pioneer AF trial started using NOACs. They studied rivaroxaban. So this was a multi-center randomized open label trial. It combined the regimens of rivaroxaban with single or dual antiplatelet therapy. So approximately 2,000 patients were divided into three major arms. One arm received lower dose of rivaroxaban. Another arm received a higher dose of rivaroxaban, that is about 15 milligram plus the clopidogrel. And the last arm, that is group 3, received warfarin with DAPT. Now, the Kaplan-Meier graph suggests that rivaroxaban with P2 vital inhibitor had the lowest bleeding risk, that is about 16%, and rivaroxaban with DAPT showed a slightly higher bleeding risk, that is 18%, whereas warfarin and DAPT showed a major risk, that is approximately 26.7%. So there was a significant drop in bleeding with the use of rivaroxaban with P2 vital inhibitor or rivaroxaban with DAPT. Hence, they also showed that the thrombotic event, that is the major thrombotic events in all these three groups, was almost similar, and there was no increased risk of thrombotic events with the rivaroxaban with DAPT or P2 vital inhibitor. So the implication of Pioneer trial was we can drop aspirin, can use another P2 vital inhibitors, and usage of rivaroxaban 15 milligram was considered because lower dose of rivaroxaban was associated with almost similar bleeding. Then came the redual PCI. Redual PCI studied dabigatran. Here also approximately 2,000 patients were randomized, and they were randomized into three arms. One was dabigatran 110 milligram twice daily with P2 vital inhibitor. Another was dabigatran 150 milligram twice daily with P2 vital inhibitor. And the last arm was warfarin with P2 vital inhibitor and aspirin. So they took a mean duration follow-up of approximately 14 months. They found that both the arms, that is dabigatran 110 milligram dual therapy and 150 milligram dual therapy, showed significant decrease in the primary endpoint, that is major or minor bleeding, as compared to warfarin triple therapy. So TIMI major bleeding also was lower with dabigatran 110 milligram and 150 milligram dual therapy as compared to warfarin triple therapy. Here, there was slightly increased risk of thrombotic events with dabigatran as compared to warfarin. However, it was not statistically significant, but there was still a slightly increased thrombotic risk with use of dabigatran. Next major trial was the Augustus trial. The Augustus trial was a large trial. It included approximately 4,600 patients, and it studied the agent of apixaban. So there were two arms. One was apixaban, which was 5 milligram twice daily, and warfarin. Each of these arms received aspirin and placebo. So the primary outcome was major or clinical relevant bleeding throughout the 6 months, and secondary outcome was MI, stroke or stent thrombosis. The Augustus trial showed that the combination of apixaban with placebo had the lowest form of bleeding, whereas the warfarin with placebo had a slightly higher side of bleeding. And apixaban with aspirin was approximately 13.8, and warfarin with aspirin had the highest cumulative incident of bleeding. So out of all these trials, we can come to a conclusion that dropping the aspirin can be a major factor for reducing the thrombotic bleeding events, and there was no significant decrease in the thrombotic events. एक break लेते हैं. So it is important to note what should be the time frame for triple therapy. So out of all these trials, we have come to a conclusion that aspirin, dropping of aspirin can reduce a significant bleeding risk, and with not so significant increase in thrombotic events. So analysis of those various stent thrombosis trials suggested that most increased risk of stent thrombosis was early, that is within 30 days of randomization. And there is a temporal relationship between the bleeding and ischemic risk. So recurrent ischemic events, that is specifically stent thrombosis, they tend to occur early after PCI, and as the time passes by, the stent thrombosis risk goes on a downtrend. Whereas bleeding risk, it is constant, it is cumulative, and it increases over a period of time with long-term and potent antithrombotic therapy. Hence, this trial suggests that the stent thrombosis risk is higher in the early part, whereas it decreases in the lower part, whereas bleeding is over a period of time. So we conclude from the trials that with the NOACs, the major bleeding was less, Use of NOACs with P2 vital inhibitor without aspirin should be preferred treatment option. Warfarin regimen should be avoided because they showed a higher bleeding risk. And the risk of stent thrombosis and other ischemic events is high. High aspirin use for 30 days is reasonable. So finding those the treatment, that is antithrombotic sweet spot, should include the right combination of antithrombotic agent at the right dose, duration to reduce the ischemic events as much as possible at minimal cost of bleeding. So North American consensus in 2021 came up with the management plan for patients undergoing PCI with AF. So they divided into three major categories. That is, one is the default strategy, another is the patient with high ischemic or thrombotic burden and low bleeding risk, and the last arm, that is patient with low ischemic or thrombotic with high bleeding risk. So the default strategy, they suggested that in the patients who are undergoing PCI, during the peri-PCI period, that is up till the discharge, the patient received oral anticoagulant therapy and dual antiplatelet therapy, which includes aspirin and P2 vital inhibitor. And right at the time of discharge, the aspirin has to be dropped, and the patient should continue the double antiplatelet therapy in the form of oral anticoagulants and P2 vital inhibitor for up to 12 months. And once the patient completes the 12 months and once the risk of stent thrombosis or the thrombotic burden is on the lower side, the P2 vital inhibitor can also be dropped and the patient can continue oral anticoagulant alone after 12 months for the risk or reduction in risk or stroke. So the middle arm shows the patients with high ischemic or thrombotic risk and low bleeding risk. So these patients during the peri-PCI period, they should receive triple therapy in the form of oral anticoagulants with DAPT as with the default strategy, but they should continue the triple therapy for first month. That is, they should receive both the aspirin, P2 vital inhibitor and oral anticoagulants for up to 1 month, that is 30 days, when the risk of thrombotic events is on a higher side. And after 30 days, once the risk lowers down, the patient's aspirin can be dropped and the patient can be continued on double therapy, that is oral anticoagulants with P2 vital inhibitor up to 11 more months, that is up to 12 months. And after 12 months, the P2 vital inhibitor can be dropped down and the patient can be on oral anticoagulant alone for the risk of stroke. Now the patients with low ischemic or thrombotic events, or they are having a high bleeding risk, such patients. So such patients, that management is similar to the default strategy, that is triple therapy, that is oral anticoagulants and DAPT. And once the patient is discharged, the patient is on dual antiplatelet, patient double therapy, that is oral anticoagulants and a P2 vital inhibitor. But the duration for this treatment is less, that is for up to 6 months only, because the bleeding risk here is high and the ischemic or thrombotic risk is slightly on a lower side. Hence, they continue the double therapy for 6 months, and after 6 months, the P2 vital inhibitor is then dropped down, and the patient continues to have oral anticoagulant alone after 6 months. Though this is the trade-off for the patients requiring the default strategy for the patients with high ischemic and thrombotic risk and the patient with low ischemic and thrombotic risk. They further gave a pragmatic algorithm for management of AF requiring oral anticoagulants undergoing PCI. So they considered three major things, that is pre-procedural consideration, the procedural consideration and post-procedural consideration. So the pre-procedural consideration was defining the appropriateness of PCI procedure, whether the patient actually requires PCI or not. The ischemic, thrombotic and bleeding risk stratification as by the various scoring systems. And management of such patients, antithrombotic management should be in the terms of oral anticoagulants, though NOAC should be preferred in most of the patients. Warfarin in terms should be avoided. If it is chosen, the INR should be at the lower end of the therapeutic range, that is up to that is from 2 to 2.5, and oral anticoagulant therapy should be maintained for lifelong. Then antiplatelet therapy, aspirin in the peri-PCI phase and should be continued through the hospital discharge, but once the patient is discharged, aspirin to be dropped. Clopidogrel is the P2 vital inhibitor of choice. Ticagrelor can be used alternative in high ischemic and low bleeding risk patients, and prasugrel, because it has a higher bleeding risk, is to be completely avoided. Discontinuation of single antiplatelet at 1 year in most of the patients. Earlier SAPT discontinuation, that is 6 months in a low ischemic group, should be considered. whereas prolonging the single antiplatelet for more than 1 year for select patients with high ischemic risk and low bleeding risk can be considered. So the strategy, whether double or triple therapy, so double therapy regimen, that is oral anticoagulants plus P2 vital inhibitor immediately after hospital discharge for the most of the patients, and triple therapy should be extended for a limited period of time for the patients with high risk of ischemic and low bleeding risk. The procedural consideration which to be considered are the vascular access, that is radial, considering the lower risk of bleeding is to be preferred over the femoral. Stent selection is important, that is newer generation regulating stents with lower risk of stent thrombosis should be used in such patients. And the post-procedural consideration, there should be a close monitoring, reassessment of the risk profile in the form of the various risk stratification scores, and also recommended use of PPIs and to avoid NSAIDs to reduce the bleeding complications. So the take-home message from here is that AF with PCI is a double-edged sword. Most of the patients have multiple comorbidities, keeping them at high risk of bleeding events as the same as thrombotic events. These patients should be given dual inhibition for duration depending on their risk, and thereafter to continue a single antiplatelet and NOACs. NOACs are proven to be non-inferior to warfarin in AF and PCI cases, as can be used more conventionally with no monitoring of therapeutic INR. The cost factor and availability of ideal reversal agent is actually an issue with NOACs. The subset of the patients with valvular heart disease, prosthetic valves, and having ACS has to be evaluated in the trials. Hence, we conclude that the North American consensus has given us a template for management of such patients, and it can be used as a go-to consensus for the management of such patients. That's it for today. Thank you.